All right, so my topic is case B. I apologize. I've had to record this very many times and then realized my microphone wasn't working, so I've had to record it again. My topic is about Mr. L, who is 40 years old with a asthma diagnosis at age 25 and a history of allergic rhinitis. His presenting concern is shortness of breath, wheezing, and nighttime symptoms. His vital signs are all within normal limits except for his oxygen saturation at 94% on room air. His physical exam includes audible wheezing, prolonged expiratory phase, no cyanosis. His diagnostics include a spirometry forced expiratory volume in 1 second at 78% predicted and a 12% improvement after using a bronchodilator. His methacholine challenge PC20 is 1.0 milligrams per mil, which is a low value. His chest x-ray is normal. His allergy testing is positive for dust mites and pollen, and other background is that he's a recreational athlete with poorly controlled asthma, and despite using a low-dose inhaled corticosteroid, he continues to experience symptoms and frequent rescue inhaler use. So the most likely diagnosis is poorly controlled allergic asthma with mild asthma exacerbation. So the anatomy and physiology of the respiratory system. The respiratory functions to exchange gas, oxygen, and carbon dioxide between the atmosphere and blood through 3 key steps. Ventilation, which moves air in and out of the lungs. Diffusion, which is gas exchange between alveoli and capillaries. And then perfusion, which transports oxygenated blood to pulmonary circulation. The airway anatomy includes air passing through the nasopharynx, oropharynx, to the trachea, bronchi, bronchioles, alveoli, ducts, and the alveoli. Gas exchange occurs in the alveoli, which are lined with surfactant, which is a lipoprotein that helps reduce surface tension and prevents collapse during air expiration. The bronchial walls are very important in this case, which include 3 layers. The epithelium, which includes mucus-producing goblet cells and ciliated cells for mucociliary clearance. Smooth muscle, which controls airway diameter, and the connective tissue that helps supports and provide elasticity. The sympathetic nervous system in the respiratory system stimulates beta-2 adrenergic receptors, which results in bronchial smooth muscle relaxation and bronchodilation, while the parasympathetic nervous system releases acetylcholine, which causes bronchoconstriction and mucus secretion. Several types of neuroreceptors help regulate breathing, such as the irritant receptors that detect harmful substances and trigger coughing. Stretch receptors allow the sense lung volume to prevent overinflation. J receptors respond to pulmonary capillary pressure. Chemoreceptors in the brainstem and circulatory system monitor blood pH, PaO2 and PaCO2, which adjusts ventilation accordingly to maintain homeostasis. The ventilation and perfusion balance, or VQ balance, helps to determine efficient gas exchange and requires matching of airflow and blood flow. It's important to note that both ventilation and perfusion are greatest at the bases of the lungs due to the effect of gravity, and that oxygen diffuses from the alveoli, where the concentration is higher, to pulmonary capillaries, where concentration is lower until the equilibrium is reached. And then that carbon dioxide diffuses in the opposite direction for during exhalation. So the pathophysiology of asthma. Asthma is a chronic inflammatory obstructive disorder. It is characterized by airway hyperresponsiveness, variable airflow limitation, and inflammation. It is often reversible, but chronic inflammation can lead to airway remodeling over time. So, a trigger or allergen exposure causes activation of dendritic cells in the airway epithelium, stimulation of Th2 cells, and cytokine release. So, the mast cells in this inflammatory response release histamine, leukotrienes, prostaglandins, and bradykinin, which causes bronchoconstriction, edema, and mucus secretion. The Th2 lymphocytes are important. Interleukin-4 promotes B cell class switching to IgE. Interleukin-5 activates eosinophils, and interleukin-13 stimulates mucus production and airway remodeling. B cells produce IgE, which binds to the mast cells and amplifies the allergic response. Eosinophils release major basic protein and peroxidase, which damage the epithelium and perpetuate chronic further inflammation. Neutrophils contribute to the severe response, and corticosteroid. Neutrophils can also contribute to corticosteroid-resistant asthma phenotypes. Basophils reinforce IgE-mediated inflammation. So there are kind of two phases in asthma. There's an early phase response, which occurs within minutes. This is mediated by mast cell degranulation, again causing the acute bronchospasm, airway edema, and mucus hypersecretion. And then there's a late phase response, which occurs 4 to 8 hours later, 4 to 8 hours later, which includes recruitment of the eosinophils, lymphocytes, and neutrophils, as well as epithelial cell damage and airway remodeling occur in this phase, which includes thickening of the basement membrane, smooth muscle hypertrophy, and fibrosis. Airway remodeling is very important, and smooth muscle changes are both as a result of the repeated inflammation that asthma occurs in asthma, which over time causes the thickening of the airway wall, and this leads to decreased elasticity, reduced lumen diameter, and chronic airflow limitation, and even inflammation between attacks. Again, this is all really due to the inflammatory cells, and over time, these structural and cellular changes make that bronchial smooth muscle very hyper-responsive, causing the exaggerated constriction to stimuli that would not normally affect an airway. So the diagnostic findings related to the patho includes the spirometry, the FEV being at 78% with a 12% reversibility after the bronchodilator shows that there is a reversible airway obstruction. This is a very key diagnostic feature of asthma because it shows that the airway obstruction is variable and treatable, which separates asthma from other chronic obstructive lung diseases. The methylcholine challenge again indicates that there's a high airway sensitivity. It means that it takes very little for the airways to be triggered and bronchoconstriction to occur, which again is a hallmark sign of asthma. Allergy testing shows that there's an IgE-mediated allergic response, and that again, this response is triggering that mast cell activation, histamine release, and further exacerbating the asthma symptoms. That mild hypoxemia indicates that there's the airway narrowing, and then the VQ, ventilation to perfusion mismatch, indicating there's a lower oxygen exchange and hypoxemia as a result. Chest X-ray shows no structural disease. It helps rule out that there is no pneumonia, COPD, because it is a normal X-ray. The nighttime symptoms indicate that there may be some worsened dust exposure in the bedroom, and the circadian cortisol changes, which is the body has a natural way. It increases airway inflammation and decreases lung function kind of during sleep, and so his symptoms may be exacerbated. There may be a late phase response, And there also may be some bedroom allergens such as dust mites, and just, the air he's breathing in could be triggering at night. Treatment options include, the ultimate goal is to minimize its symptoms, prevent exacerbation, improve lung function and quality of life. Non-pharmacological interventions in this case, we want to identify and eliminate the triggers. So we want to wash the bedding weekly in hot water, remove, any carpet that could have dust, use HEPA filters, and review and reinforce inhaler technique, as well as go over, his asthma action plan and adjust accordingly. Pharmacological management, we want to continue to use that low dose uh, inhaled corticosteroid, which helps reduce the airway inflammation, and then a short acting B2 agonist, which is what he's been using for the acute relief. Remember that the B agonists help asthma by stimulating B2 receptors to relax airway muscles, which can help lead to bronchodilation and easier breathing. If the control is inadequate, which his asthma control is continuing to be inadequate, we can consider adding a long-acting B2 agonist such as formoterol, and then consider a long-acting muscarinic antagonist, which help block the effect of acetylcholine on the smooth muscle cells of the airway. We can also add leukotriene receptor antagonists or montelukast for the allergic. These are great for allergic or exercise-induced asthmas. These just help block the inflammatory chemicals released during the asthma response. Finally, we can try some allergy shots or immunotherapy, which will help reduce the IgE mediated response or sensitivity. We can try some biological agents. These are kind of being studied and investigated more, but they help target specific cytokine pathways and also help improve steroid responsiveness. Finally, azithromycin may be used for the anti-inflammatory properties that it has for chronic severe asthma. And exercise-induced asthma, again, just continue using the low dose for formoterol or the short-acting beta agonists prophylactically. Education is very important. Proper use, adherence, and trigger avoidance are key to preventing asthma exacerbations. Finally, potential complications. If left untreated, asthma can cause status asthmaticus, which is severe unrelenting bronchospasm, leading to rising partial pressure of carbon dioxide in arterial blood, respiratory acidosis, and respiratory arrest and death if untreated. Airway remodeling is also another complication which can cause irreversible airflow limitation, similar to what we see in the chronic obstructive asthma or COPD. Sleep disturbances, fatigue from nocturnal symptoms, anxiety, decreased exercise intolerance, and hypoxemia or hypercapnia during the severe episodes of asthma. It's very important to be educated on asthma, the effects of asthma, and how to prevent exacerbations.